Today we're going to speak about emergency interventional sonography in children and the applications of sonography for urgent and emergent situations. We'll focus on practical aspects that we encounter in pediatric radiology and to a lesser degree in the care of adults with either congenital disorders or unique situations that require children's hospital support, and care in the emergency or urgent setting, where interventional radiology is called upon to support the care of the patient, and particularly in situations where sonography provides unique and or critical advantage in the performance of the interventional radiological procedures. These elements together allow us to provide more successful care and particularly successful partnership with medical and surgical disciplines. We'll focus on 7 procedures today: vascular access, the management of empyema in the chest, emergent pericardial effusion drainage, abscess drainage, percutaneous nephrostomy placement, cerebrospinal fluid pseudotumor management in patients with ventricular peritoneal shunts, and lastly, some unusual situations where foreign body removal is requested on an emergent basis. We will look first at emergency vascular access. Now, in children, we tend to utilize vascular access emergently in the pediatric intensive care unit in patients who are in shock, either from sepsis, cardiogenic shock, and most often we are requested to perform vascular access for femoral venous access, and most of the time, since the patient's in shock, the clinicians have had a difficult time gaining arterial access, and we support the patient with arterial access in addition to central venous access. Very important in these patients is to always have a plan B, an alternative plan, where if femoral vascular access is not successful, then we will approach either subclavian or jugular vascular access. In the neonatal intensive care unit, usually it's in the setting of bowel perforation, necrotizing enterocolitis, or sepsis that we're requested to support the team with vascular access. Other children who are able to come down to the radiology department may have sepsis with no peripheral venous access, and these cases do not necessarily need to be performed at the bedside, but most commonly in the interventional radiology suite. And patients who require vascular access urgently are requested to have our support because they've had previous vascular access, and we refer to these as vascular access casualties, where they've had thrombosis with scarring and stenosis or occlusion of vessels precluding traditional central venous catheter access. The 3 patient populations we tend to see this in are in the cardiac patients, cystic fibrosis patients, and patients with short gut syndrome with TPN-dependent situations. So first, ultrasound-guided vascular access. The most important portion of the procedure is maintaining visualization of the tip of the needle at all times, and ideally proceeding with a single wall puncture through the superficial portion of the vein wall, as we see with the needle on the bevel tip centrally located within the lumen. This hockey stick type probe gives us tremendous advantage that is very flexible and ergonomically very advantageous for vascular access in both arm, neck, and vascular access in the femoral vessels. The technique that we utilize incorporates freehand technique, and we begin by finding the target with the transducer. It's very important to visualize the back wall of the vessel in crisp detail. This lets us know that we are centrally located in the long axis view. Then we fix the transducer hand on the target, stabilizing our hand with the transducer. And a very important point, we avoid moving both hands simultaneously. We either fix the transducer and move the needle in a subcutaneous plane, or we sweep the needle back and forth until it finds the sound plane, or we fix the needle in place and move the transducer to find the orientation that we are in misguidance for correction. Then we follow the needle tip, and again, always follow the bevel and the needle tip, and just like a plane landing in a nice oblique plane coming down to the superficial wall, and then with a smooth puncture, a single wall puncture technique. 2 different planes that we provide vascular access. The majority of the time it is in the longitudinal plane, or the long axis plane, where we see the tip of the needle superficial to the vessel wall and then centrally located within the lumen, always looking for the comet tail artifact at the tip of the needle, whether superficial or within the vascular lumen. In the short axis view or the transverse plane, we see the needle as a dot, superficial to the vein wall, indenting the vein wall, and then puncturing into the vein wall, centrally located in the lumen. Pitfalls and artifacts are important for us to understand. The two most common in vascular access are the oblique crosscut artifact and the beam width volume averaging artifact. We'll look at both of these in animation and graphic forms. Here we see two still images of the oblique crosscut artifact. In the image top left, we see the full alignment of the needle, and the bottom right image, with slight movement and rotation of the transducer, we see that we lose the proximal and distal portions of the needle, and this is a critical pitfall. Here we see the needle in good alignment, but a slight rotation of the transducer, we lose the proximal and distal portions of the needle. Now, when performing femoral vascular access, particularly in the very small child or the child who is small and in shock that has markedly attenuated vessels, many times the vascular lumen is 1 millimeter or less, and we're required to gain access to that lumen. As you see in this long axis view of the common femoral vein, the number 1 and number 2 indicators indicate the locations where we prefer to proceed with access first in the ascending portion of the femoral vein, and note is made that the femoral head is below or deep to the vein. So we would approach first in site number 1, and if that fails, then we are left with site number 2. Site number 2 is always our backup site, and as we see with the arrow, it is lined up very nicely in the plane of needle access and the direction of the descending portion of the common femoral vein. This image shows the arrow pointing towards the portion of the femoral vein in the ascending portion that we'll target. Now we see the bevel of the needle indenting the vein wall, and then next with the bevel clearly centered within the vein wall. Notice the small size of this infant vein. The width of the vein is essentially as long as the bevel is, and so we have very little room for failure. Very important to notice that we are in both with visual and tactile feedback. We feel the vein wall pop, and we see the vein wall indent and then release, and then many times we can see blood moving retrograde in the needle. Once the needle is in place, another maneuver that is very helpful is to watch the guide wire exit the needle tip and move smoothly in an ascending fashion in the vein towards a more proximal position in the iliac region, and the arrow is on the 0.18-inch guide wire. In very small children, one maneuver that works out very well, here we have two images of the common femoral vein, the top one prior to access and the bottom one with the needle and the guide wire in place. And the image on the right shows that we are able, in very small children, where the black arrow is the straight arrow, we can make a skin puncture well below the diaper line to decrease the risk of vascular infection and blood-borne infection regarding or associated with the vascular access procedure and long-term maintenance of the vascular lines. And we can see the curved arrow is where the needle would actually enter the vein. So we have a nice long tunnel in these very small children that the vascular access needles allow us the opportunity to produce a single puncture tunneled central venous catheter and avoid the diaper line and the secondary contamination. In this animation, we see the classic long axis approach or the longitudinal approach, single wall puncture technique with the needle and the guide wire advancing in the vascular lumen. Here we see volume averaging artifact. We approach the needle into the vein and it looks like the needle is in the lumen, but then we look either in the transverse plane or move the transducer in the long axis view to see that we are adjacent to the vascular lumen, not within the vascular lumen. One last pitfall: if we move too slowly, we can actually dissect the intima from the media and then have secondary displacement of the wire in a subintimal dissection plane that will cause complications to follow. So again, we want to move in with a brisk maneuver to avoid this pitfall. When we're not approaching femoral venous access, the most common approach in the interventional radiology department is to use the arm approach for central venous access, or a PICC line, a peripherally inserted central venous catheter. Here we see in that long axis view the 21 gauge needle accessing following the transducer placed in the sound beam with this very lightweight hockey stick probe. And here we see the needle tip clearly in the basilic vein with good central location with a single wall puncture technique.